So, good morning, Chairperson. Good morning, everyone. So, I'm the opening batsman. So, without wasting any time, let us start our today's topic. So, I would like to thank Dr. Polash Kumar for giving me this topic. This is a very important topic for the PGTs also. For my topic is anesthesia for endoscopic neurosurgery. So as you know that the endoscopic neurosurgery is revolutionized the brain, skull-based surgery and various spine surgery due to various advantages. Like it is a basically keyhole surgery, so it reduces the tissue trauma due to smaller incision. It leads to faster recovery, patient goes back home faster, earlier, and due to the smaller incision, it is cosmetically superior and lower risk of infection also. So there are various surgery, as you can see, that we are doing nowadays by endoscopic procedure. Some brain surgeries are there, some spine surgeries are there. Among them, most common is the non-communicating hydrocephalus, where we are doing the endoscopic third ventriculostomy. I will be dealing with this topic in details after a few slides. And apart from that, many various ventricular and paraventricular cysts, tumors, and hematomas like subdural hematoma, ICH drainage, all these can be done by the endoscopic procedures. Apart from those, various spinal procedures like surgery for syringomyelia, for the transthoracic endoscopic sympatherectomy, arthroscopic microdiscectomy, lumbar discectomy, VATS, kyphoplasty, spinal tumor surgery, nowadays all can be done through the endoscopic procedures. Now, what is in general goal for the anesthetic management? So first important thing is that you have to keep your patient calm, immobile. Ensure safety, rapid emergence from the anesthesia for prompt neurological assessment, because just after surgery, neurosurgeon usually they want for immediate neurological assessment. Minimize postoperative complication, facilitate intraoperative neurophysiological monitoring techniques, and management of the intracranial pressure. Now, this is very important. During the surgery, anesthesiologist should be having close observation on the surgical video screen and surgical field, and neurologic and anesthetic monitoring systems. Now, neuroendoscopic procedure is most commonly used, as I have already said, that in case of the non-communicating hydrocephalus, in form of endoscopic third ventriculostomy. And visualization of the surgical site is achieved only through a bar hole instead of a craniotomy or a mini craniotomy. And through that bar hole, usually what they do, they put a plastic tube-like thing which is known as introducer or trocar, and through that they introduce the endoscope through the bar hole. Through the frontal cortex, they reach the ventricular or the paraventricular structures. And during the procedure, they continuously irrigate through the saline or ringal lactate solution. And during endoscopic third ventriculostomy, the floor of the third ventricle is fenestrated to create a flow between the ventricle and the subarachnoid space. So preoperative issues mainly concerns are you have to treat the raised intracranial pressure, and these patients many a times present with nausea, vomiting, so aspiration is a big concern. And there is a possibility of the metabolic derangement also. And if you are planning for a central venous line placement, if the patient has already undergone a VP shunt surgery, so you have to know the location of the shunt also. Now coming to the intraoperative concerns. General anesthesia remains strongly advocated. Why? Because you need to keep your patient immobile. Although local anesthetics and the sedation has been already described. Nitrous oxide is better avoided for the possibility of expansion of the pneumocephalus. Invasive arterial monitoring is highly recommended, because throughout the procedure there are the chances of the hemodynamic swings, and there is also chance of the rupture of the basilar and perforating arteries also. Now, the pressure generated by the continuous irrigation system may lead to intracranial circulatory insufficiency. That is why what happens in the endoscopes, there is a side port through which you can attach your transducer and you can monitor ICP. And also you have to closely monitor the mean arterial pressure also to ensure adequate cerebral perfusion pressure. Significant increase in the intracranial pressure and direct stimulation and damage of the hypothalamus by the irrigating jet that leads to cardiovascular instability, and all sort of dysrhythmia can happen. But the most common, many a times we have faced this thing. Most common is the bradyarrhythmia. And if this happens, you have to immediately tell your surgeon that this is happening. They have to irrigate out some amount of fluid, or they have to stop the irrigation fluid for some time, and after that usually it is corrected. If not, you have to give atropine and all. Stimulation of the hypothalamus in the posterior part causes the tachycardia and increased blood pressure. And if it is stimulated the anterior part of the hypothalamus in the preoptic area, usually that represents as a bradycardia and hypotension. Hypothalamic injury in the postoperative period may lead to SIADH or diabetes insipidus. And usually either I have already told they use warm ringal lactate solution or normal saline. So if in warm ringal lactate solution many a time causes hyperkalemia in the postoperative period, and warm normal saline, if the volume goes more than 500 ml, usually it causes CSF acidosis. Now the irrigation fluid usually kept at a rate of 10 to 50 ml per minute, but though due to hemostasis they use a higher rate also. Hypothermia due to the exchange of CSF and irrigation fluid are most common in the pediatric age group, and VAE, though incidence is less, but it has also been reported. Pneumocephalus, transient herniation syndrome due to CSF drainage and irrigation have been reported. Delayed emergence up to 15% has also been reported. And postoperative pain usually in endoscopic procedure is very less because they are doing only a bar hole, and they also infiltrate local anesthetics also. Postoperative concern, transient neurological deficit are most common. Hyperkalemia, I have already said, confusion, transient pupillary dysfunction, transient hemiplegia, memory loss, all these things are common. High pressure level inside the endoscope are reported to be associated with delayed arousal and higher rate of postoperative complication. Usually within the endoscope the pressure is kept less than 30 millimeter of mercury. Okay. Respiratory arrest has been reported in children, and diabetes insipidus, hypothalamic dysfunction is common. Postoperative electrolyte monitoring is therefore very, very important. Late complication includes meningitis and ventriculitis. Now a little bit about the minimally invasive spine surgery. Now the smaller incision is possible, and the endoscopic procedure possible because of invent of and use of various gadgets like advanced operating microscope, fluoroscopic guidance, stereotactic neuronavigation system, special instruments like tubular retractor, disc spade dilators, special case devices. Endoscopic procedure, same advantages are there: less postoperative pain, less recovery time, and less hospital stay. So currently both regional and general anesthesia are safe and advised for the lumbar spine surgery. Regional anesthesia may be better choice in patient with higher risk of complication of general anesthesia because it causes less use of opioid, less nausea, vomiting, less urinary retention. Though the motor examination cannot be readily or reliably performed with electrophysiologic monitoring if you are using neuroaxial technique. Now last but not least is the robotic assisted spine surgery. This is also coming up. It has been already employed in case of screw and rod insertion in spine surgery, vertebroplasty, tumor resection, and for the anesthetic nerve root block also. So it decreases the likelihood of the collateral damage of the structures adjacent to the target site. This is the beauty of this robotic technique, and less than optimal hardware placement. Shorter surgical time, reduce exposure to the radiation, and it also decreases your, the fatigueness of your colleague surgeon also. So to summarize, minimally invasive technique has continued to be improved variables such as the recovery time, postoperative time, length of stay, and patient discomfort. Anesthesiologists contribute to the outcome of the patient through an awareness of the patient's condition and comorbidity, an understanding of the procedure and its possible complication, and a working knowledge of the currently accepted techniques are very, very important. So these are my references. Thank you all for patient hearing.
Thank you.